Hello, this is Therapeutic Updates, Best Practices, and Barriers to Care in the Treatment of Advanced Non-Small Cell Lung Cancer. My name is Delilah Katz, and I'm a clinical pharmacist in oncology at UMass Memorial Medical Center in Worcester, Massachusetts. By the end of the session, the attendee will be able to describe recent therapeutic updates to molecular testing and biomarkers in determining the natural course of disease and associated therapy, describe barriers to the use of targeted treatment modalities, apply recent research in systemic targeted therapy and clinical practice guideline recommendations in a patient with advanced non-small cell lung cancer, and be able to design a treatment plan for a patient with advanced non-small cell lung cancer to optimize safety, efficacy, tolerability, and reduce barriers to care. So let's talk a little bit about what we're looking at in terms of cases. The estimated number of new cases in 2013 is upwards of 228,000, making it the second leading cause of new cancer diagnosis. And it is the leading cause of cancer mortality in both men and women, responsible for approximately 27% of all cancer deaths. The 5-year survival rate is 16%. Overall, we see a good trend. The incidence rate has been declining in men over the past 2 decades, and from 2005 to 2009, lung cancer incidence rates decreased by 1.9% per year in men and 0.3% per year in women. The better statistic is the 1-year relative survival for lung cancer, which increased from 37% in 1975 to 1979 to 44% in 2005 to 2008, obviously largely due to improvements in our surgical techniques and also combined therapies. Unfortunately, we still have only 15% of lung cancers diagnosed at a localized stage, for which the 5-year survival rate is 52%. And that is why we have an overall survival as low as we do at 16%, because it's really reflecting the fact that the majority of lung cancer patients are being treated as advanced and metastatic disease. In 2011, ASCO came out with a focused update of the 2009 ASCO Clinical Practice Guidelines on chemotherapy for stage 4 non-small cell lung cancer. I've highlighted the key points here. The most important are that after 4 cycles, there's really a decision point. You can continue on for another 2 cycles of 2-drug doublet therapy, but you really shouldn't go more than 6 cycles total. For patients with stable disease or response after that initial 4 cycles, they can go to an immediate treatment with an alternative single agent, which we're now calling maintenance, such as pemetrexed in patients with non-squamous histology, docetaxel, or erlotinib. And of course, there are some limitations to all of the data that they were looking at up until that point, and they really hadn't come to a decision about whether it was more important to take a break or whether it was more important to continue on to maintenance. Now let's take a look at the NCCN 2013 first-line therapy for stage 3B or stage 4 non-small cell lung cancer. Obviously, the important thing is determine histology, as that will direct our therapy. Squamous, you're looking at either a doublet therapy or cisplatin vinorelbine plus or minus cetuximab. Non-squamous is where we really have more options, the doublet chemotherapy or the carbopaclitaxel bevacizumab, or cisplatin vinorelbine plus or minus cetuximab if you don't have molecular diagnostics. If you do have molecular diagnostics available and they're positive, there's more selected therapy if you have an EGFR mutation or if you have an ALK positive mutation. And just a note here for doublet therapy, at this time the NCCN does not specifically recommend any of the agents over the other agents, and have in fact added albumin-bound paclitaxel as the latest drug to be considered as part of the cisplatin or carbo additive for doublet therapy. This is in conjunction with the new FDA labeling. Biomarkers are something that we are going to be spending quite a bit of time in this talk discussing, and so I've just laid out the definitions there for you. VEGF, EGFR,